When a patient presents with yellowish subretinal deposits and pigmentary changes in the macula, the immediate reflex is often an age-related macular degeneration diagnosis, but relying solely on these superficial features leads to critical misdiagnoses. To bypass this cognitive bias, we establish a strict diagnostic threshold, the golden triage rule. Any patient presenting with AMD-like signs who is under 50 years of age represents a critical clinical red flag. Age-related macular degeneration is defined precisely by its name. It is a pathology tied strictly to the aging process. If you observe these structural signs in a demographic under 50, the presentation indicates a different phenotype, such as an inherited macular dystrophy or a familial Drusen syndrome. Assigning an AMD diagnosis to a younger patient prematurely ends the diagnostic search. In many cases, these structural changes in the macula are early biomarkers for systemic conditions that require immediate medical intervention. To isolate the true pathology, clinicians must systematically correlate OCT morphology, fundus autofluorescence imaging, and the patient's baseline demographic data. Focusing on structural signs alone risks missing the specific demographic markers that dictate management, potentially leaving underlying conditions untreated. One of the most frequent AMD mimics is idiopathic central serous chorioretinopathy, or CSC. Multiple chronic episodes can leave behind widespread mottled pigmentary changes that visually resemble intermediate AMD on a standard fundus exam. The baseline demographic for acute CSC is highly specific. It primarily affects middle-aged males with highly anxious, rigidly organized type A personalities, or individuals with a recent history of corticosteroids use. The physiological mechanism here is distinct from AMD. CSC is driven by a localized accumulation of serous fluid that physically detaches the neurosensory retina from the underlying retinal pigment epithelium. This makes the OCT scan the primary differentiator. In a pure CSC presentation, there is a complete absence of actual sub-RPE drusen, leaving only an isolated, clear fluid space. Over time, the clinical picture gets complicated. As the fluid from repeated episodes resorbs, it leaves a degraded, mottled RPE footprint that visually mimics the intermediate stages of macular degeneration. Practitioners must also watch for atypical demographics. In older Caucasian females, CSC can present with neovascular complications that mirror polypoidal choroidal vasculopathy, making the differential incredibly challenging. And while primary drusen structures are absent, monitor these patients closely. Chronic CSC can trigger secondary macular neovascularization. By confirming the absolute absence of drusen and identifying isolated serous fluid on an OCT slice, you successfully rule out AMD and shift the focus to fluid management. The next major category of mimics encompasses the inherited macular dystrophies. These typically present bilaterally, display highly symmetrical lesions, and feature a strong family history. Unlike the older baseline demographic of true macular degeneration, these dystrophies usually manifest early, in childhood or young adulthood. To effectively separate dystrophy-related atrophy from AMD, fundus autofluorescence imaging is mandatory. Inherited dystrophies typically present with a brighter autofluorescent background, but the definitive biomarker is structural. You will see a distinct, sharply defined ring of healthy, spared RPE immediately surrounding the optic nerve head. A classic example is Best's disease. It classically presents in patients between the ages of 3 and 15 as a single, large, intensely bright subfoveal lesion, often described as an egg yolk. Over time, the natural progression of the disease causes this sharply defined lesion to break down and resorb, leaving a fragmented, scrambled egg appearance. But there is a specific dystrophy that directly complicates our triage rules: adult vitelliform dystrophy. Because it presents in adults over 50, it overlaps precisely with the primary AMD demographic. AVD lesions are significantly smaller than those seen in Best's disease. To the naked eye, they look remarkably similar to standard drusen, leading to frequent misclassification in clinical practice. The structural differentiator relies on precise topography. Despite their small size, adult vitelliform lesions are almost exclusively positioned directly beneath the fovea. This targeted, centralized positioning provides a contrast to typical AMD, where metabolic waste materials scatter in an irregular, widespread distribution across the macula. If you identify an isolated subfoveal yellow lesion and the AIF reveals peripapillary RPE sparing, you cannot assume early AMD. This presentation demands a complete dystrophy workup. The final category of mimics, inherited drusen syndromes, mirror true AMD more closely than any other differential. Cuticular drusen is typically detected during a specific clinical window, falling squarely between 40 and 60 years of age. The difference lies at the microanatomical level. Cuticular drusen are basal laminar, meaning they form through a uniform thickening of the RPE basement membrane itself. This is a mechanical contrast to typical macular degeneration. In AMD, metabolic waste material accumulates entirely beneath the RPE layer, rather than thickening the membrane. This membrane thickening produces a pathognomonic OCT signature. You will see a highly symmetrical, densely packed presentation that creates a distinct sawtooth elevation line along the RPE. Identifying this specific sawtooth morphology on an OCT scan instantly rules out early AMD and reclassifies the pathology as cuticular drusen. This brings us to early onset drusen, a classification reserved for undefined drusen phenotypes that appear strictly in patients under 50. Finding these early drusen in a younger demographic triggers a severe and immediate escalation in the patient's systemic risk profile. The clinical protocol for early onset drusen is non-negotiable. The practitioner must immediately order a urinalysis. This test screens for severe systemic conditions, specifically progressive renal diseases. The formation of early drusen shares underlying genetic pathways with these life-threatening kidney disorders. Correctly identifying these morphologies allows the clinician to initiate the necessary systemic referrals. In this context, the differential diagnosis is the primary mechanism for patient survival. Relying solely on the superficial presence of pigment changes or yellow macular deposits is a clinically insufficient strategy. This clinical decision matrix synthesizes these variables. The golden triad rule forms the primary axis, splitting cleanly at age 50. The secondary axis plots precise OCT biomarkers, sub-RPE deposits, strict subfoveal localization, basal laminar sawtooth patterns, and isolated serous detachments. When plotted correctly, you can clearly see that standard age-related macular degeneration is entirely locked out of the under 50 quadrant. Consistently apply these imaging rules. Use OCT to separate serous fluid from basal laminar thickening, and utilize autofluorescence imaging to verify peripapillary sparing. Rigorous biomolecular differentiation must replace the assumption of AMD. Executing this matrix ensures accurate neovascular management and secures the medical referrals that safeguard patient survival.